Let's come to hallucination. Hallucination means that perception without stimulus. Write it down. Perception, but without external stimulus. There is nothing external, but you perceive something. I will tell you from where it is created. Hallucinations. For example, let me give you a classical example. That you enter into a room and you feel there's a ghost. But when you put the light on, but I hope before that you'll fly away. But if you put the light on, there's nothing. So what is that? Hallucination. But if you put the light on and you find your friend smiling at you, not a ghost, real good friend, then what was that? Illusion. You see the difference between the illusion and hallucination, right? That illusion, that stimulus is there, your friend is there, but you perceived wrongly as a ghost. But hallucination means that no one is there, but you perceive there's a ghost. You get me now? But as soon as situation is clarified, you become satisfied. You put the light on, you see there's nothing, then it means this is hallucination, right? So hallucination is perception without external stimulus. Is that right? There are many examples of hallucination. For example, you are sitting here and you start hearing something. You are hearing something which is not there. No one is talking to you. There's no voice, there's no sound, but you hear someone is telling you to go to San Francisco immediately. You leave your test and rush to San Francisco. I hope you don't do that, because if you really do that, that will be delusion. I will tell you later. But hallucination is that you hear sounds maybe, but actually they are not there. Is that right? So that will be auditory hallucination. Is that right? Now let me explain hallucinations in detail, because there are many drugs or biochemical changes in the body which may produce hallucinations. First, I tell you from where the hallucination is produced. This is your central nervous system, the mechanism of hallucination. This is your visual cortex, right? You know that connections from the eyeball, they are eventually connected to the visual cortex through the visual pathway, right? Now, visual cortex has primary area, secondary area, and tertiary area, or area number 17, area number 18, area number 19. What is the real difference? All these, this is visual sensory cortex, but this is called primary cortex. This is visual secondary cortex. This is visual tertiary cortex, or simply we call it primary cortex, and secondary and tertiary together are called visual association area. Is that right? These two together are called visual association area. How do they work in a different way? Actually, this primary area, or area number 17, receives the information. It is a reception area for action potentials coming from visual pathway, right? Area number 18 analyzes the visual information, and area number 19 recognizes the visual information. Again, listen. Primary sensory cortex is concerned with receiving the sensory input. Secondary sensory cortex, which may be secondary visual cortex or secondary auditory cortex, right? Secondary cortex is usually concerned with analysis of the sensory information coming. This is the analysis area, and this is the comparing the new information with the past and trying to recognize the information. Am I clear? Now, if this is the primary visual cortex, if you electrically stimulate it, you just feel that there is some lights. There may be some, you can say, flashes of light, but you cannot make any pattern out of that. But if you electrically stimulate this area, you may find clear-cut patterns, but you fail to recognize them. But if you stimulate this area, you will even recognize the pattern, that they are vertical patterns like stripes, or they are well-formed images in this area. Let me tell you another thing. Let's suppose I write here Yeah, I've written something here. I'm going to write another thing here. Who will read this? Can you read? Make meaning out of it? Okay. Can you see it? You can see it. It means this pattern is received by area number 17. Even you analyze that lines are red color, and you analyze the color, you analyze the thickness of the lines, your mind is analyzing the angulations, but it cannot make any recognition. So it is going to area number 18 also. But when you throw this image to area number 19, 19 area say, I've never seen image like this, so it failed to recognize that pattern and failed to make any meaning. But when you take this image, it goes to primary area, then it is analyzed in secondary area, and pattern is recognized in tertiary area. You get it now, right? Now, as you know, the different part of the cortex are working in a different way. Now you imagine if someone irritates this area, you may have just unformed images, right? Unformed. If you stimulate this, there will be some patterns which you cannot recognize. If you stimulate here, maybe you find the horse is running, a well-formed image. You get it? Now, if there's some drug, or there's some toxic compound, or there's some disease which is irritating area number 17, you will perceive some flashes of light which are not there. But if you irritate area number 19 by the drugs or its toxic action, right, what will happen that you may see some well-formed images. Is that right? Same is true when you come to the auditory cortex. For example, primary auditory cortex, secondary and tertiary. If something is, there's a dysfunction and overstimulation in primary auditory cortex, you just may hear some sounds, but you cannot bring any meaning out. But if you stimulate the next area, the sounds which you're hearing you can analyze well, right? But you cannot make the meaning out of that. And if your information goes up to here, you will hear the sounds, you will analyze them, even you will bring the meanings out of that. Here, in some unknown language, which I don't know myself, I have written that rose is beautiful. Is that right? But you could not make meaning of this, but you can make meaning of this. So this is the base of hallucinations. The fundamental concept about hallucination is that either the sensory pathway is stimulated, or in some inappropriate way, your sensory cortex is stimulated. Depending upon how well structured is hallucination, we can infer which area is really irritated. Am I clear? No problem? Again, you know this is primary sensory area, isn't it? If hallucination is coming due to irritation here, you will see that there is some sensation in the arm, but you cannot interpret them. But if area little posterior to it, which is secondary area and tertiary area, you may say that someone is pressing your arm, or someone touching or caressing it, or you may find there is something hot touching you, but actually there is nothing there. This is your hallucination. So I hope the basic genesis and production of hallucination is clear in your mind. From where hallucination comes, it is your own mental phenomenon. There's nothing out in the environment. Is that clear? Now, let me tell you a few types of hallucinations. The most commonly in clinical practice, we come across visual hallucinations, right? There are visual hallucinations. You see the things which are not there, or your patient see the things which are not there. Very common causes are some drugs, their toxicity, or their withdrawal, or due to electrolyte imbalance or acid-base imbalance, biochemical changes in the blood which disturb the neuronal function, produce foci of irritation, and that may be translated into hallucinations, right? Then we can come to auditory hallucinations. Auditory hallucinations mean what? You are hearing something which is not there. The very, very classic example of auditory hallucination is in patients with schizophrenia. Schizophrenia is pronounced in many different ways. Schizophrenia is called schizophrenia, schizophrenia, schizophrenia. In my experience, whenever I ask any doctor, I come to know new pronunciation about schizophrenia. So one day I have to confirm what is the right, including my own pronunciation. But I hope you understand what I'm talking about, right? So in schizophrenia, what we really have are auditory hallucinations. Yes, ma'am, you have a question. You raise your hand.
In order to the drug to cause the hallucination, it has to stimulate the primary part.
Look, when we say there is suppose any type of hallucination, something is disturbing the sensory system from receptor side up to the cortical analysis side. For example, for visual hallucinations mean that you see something which is not there, right? It may be either from the retina or from the visual pathways or primary visual cortex or secondary visual cortex or tertiary visual cortex. Now, actually, if receptors are irritated, right, disturbed, or you can say visual pathways disturbed or visual cortex is disturbed, all these will make unformed hallucinations. Unformed hallucinations mean you may have flashes of light which you cannot recognize, but in secondary and tertiary you start recognizing the pattern. Still hallucination. For example, you are right now sitting in this room and you see that there are two elephants giving lecture to you, right? What do you think? It's hallucination or it is okay? Don't not two. You are sitting in the class. You just feel that one elephant is giving you a lecture. Now, what is the problem? I hope I'm not elephant. Yes. No, look, it may be illusion first of all, right? You think I'm a mini elephant, right? But with a little concentration, you come to know this is Dr. Najeeb. So illusion is clear, misperception, right? Hallucination mean that you see I'm giving the lecture, but you find that there's some elephant moving here, but actually there's nothing. Then that is considered hallucination. And I tell you an interesting thing. But suddenly you stand up in the class and you say, Dr. Najeeb, you are elephant. I say, I'm not elephant. You say, no, I'm sure you are elephant, right? And all of us try to convince the poor Dr. Najeeb is not elephant, but you say, no, he is elephant. He should be in the zoo. Then it means you have delusion. I will go to that. Delusions are a different problem, really more stronger problem, right? Is that clear? Yes, please.
I think that also because it was about that doubt that she has, maybe what she wanted to ask is that does it have to strictly stimulate the first area, or can it stimulate the secondary area without stimulating the first area?
Yeah, this is, let me tell you again, let me draw the diagram so that, okay, this become also a little bit. Listen, this is primary visual cortex area 17, 18, 19. Again, you can directly stimulate it and get well-formed images because here the images are stored. You are getting it. For example, by electrically you stimulate someone area 19, he sees well-formed images. He may see his mother cooking the food. You know, very clear-cut thing. But if you stimulate this area, he may find some pattern without recognition. But if you go to this area, this is just patient say, I see some lights, but he cannot make any sense out of that. Because as sensory information is moving from primary area to secondary area to tertiary area, it is getting more better analyzed and eventually recognized. Recognized as a new pattern or as old pattern. Yes, please.
Could it be a hallucination where you can see, hear, and feel at the same time?
Yeah, sometimes hallucination can be unfortunately you may have visual hallucination with that, auditory hallucination with that. What is this called? Tactile hallucinations. People do get, right? Especially in schizophrenia, when we'll talk about antipsychotic drugs, right? Many patients have auditory hallucinations plus visual hallucinations. I've come across some patients with schizophrenia. They say that they see some old men, right, who are always advising them. Now, if that is firm belief of the patient, then that will not be hallucination, that will come delusion. In schizophrenia, I will tell later, that patient may have multiple problems, visual delusions, I mean he sees the things and he hear the things and which are not there and he very firmly believes in them. Is that right? But if someone does not have a delusion, he has a visual hallucination and auditory hallucination, he may see some things, he may hear some things, but if he is not schizophrenic, he is normal, right? Or he has some toxicity of the drugs. Once the biochemical level of drugs are okay, right, patient become normal. Is that right? Am I clear? Now another example. I was coming to visual hallucinations that you can, we have already discussed. Come to the auditory hallucinations.
One more question on this.
Auditory hallucination, you hear something which is not there. Is that right? Yes, please.
On the visual,
Yeah.
do you have an example of a drug toxicity or poison that stimulates on 17 that the patient comes to you and say, I just see flashes, or another patient comes to you and say, I do see a lot of...
The typical examples are the drugs which are, many psychotropic drug can do, but the typical example is cocaine. In cocaine, sometimes patient have some hallucinations. Even though classical hallucination in cocaine is the tactile. They see the bugs moving on their skin, or they see that bugs are moving on the pillows and they try to remove it. If they really see that bugs, then if they see this bug, that is your visual hallucination. But if they just feel that bugs are crawling, but they don't see it, but trying to remove it, then it is tactile hallucination. Is that right?
So,
Then another example of visual hallucination classically seen in delirium tremens when there is alcohol withdrawal. Many patients who are heavily alcoholic, they are admitted in hospitals, and if they don't get regularly alcohol there, so when they develop alcohol withdrawal, they start developing some hallucinations and some other psychological problems. Is that right? So these are common problems there with
so cocaine is a drug that specifically attacks area 19.
no,
Because
it
only
depends.
forms vision.
Yeah, yeah.
Elements.
Yeah, but it produces many other problems also. We'll discuss when we'll talk about cocaine. Right now, I'm just talking about very basic, because these terms will again and again come when we'll discuss the drugs, that this drug is producing this side effect. So I thought first I should tell all the terms before I start the psychopharmacology. So auditory hallucination means you are hearing something which is not there. Is that right? In the same way, then there can be tactile hallucinations. Tactile hallucination, we'll talk about that. Tactile hallucinations mean you get some somatic sensations, but actually there is no stimulus. As I told you, cocaine bugs. That people who have toxicity of cocaine and they feel there are some bugs crawling on the skin, but actually there is nothing there. Is that right? Tactile hallucinations. Then there can be olfactory hallucinations. Olfactory hallucinations. Here you have to be serious. You know which area is olfactory area? Oh my God. He said olfactory cortical area is nose. Right. No, actually, look, before you come up with new things, hold on. Actually, this is the temporal lobe. Temporal lobe, laterally it is concerned with the auditory system. On the medial side, it is concerned with olfaction and emotions, and also with a very important function in differentiation of reality and imagination. This is a very important function, and it's clinically also very important. Listen, right now if you imagine something, or whenever you imagine something, when you're alone in the bed, you imagine few things, but you are sure what is reality and what is imagination, or you get confused. You're very sure, right? It means his temporal lobe works well. He knows he's cooking fantasy as he wants, but actually it's not there. Is that right? Now there is a difference in hallucination and fantasy. Don't confuse that. Fantasy is you cook yourself, you see or hear the things which are in your imagination which are not there. But you are knowing that this is your own mental phenomena you are inducing by your thought process. Hallucination is not cooked by yourself. You just feel for a while.
So it's voluntary. So
Right?
the
Fantasy may be voluntary or sometimes involuntary. So if someone has been rude to you and again thought coming back, you don't like it. Anyway, we will not talk about that into detail in fantasy because some complication may be there. Right now, You should not confuse the fantasy with the hallucination. But what I really mentioned, the temporal lobe has many functions. One of the very important function of temporal lobe is differentiation between reality and fantasy. Another very important function of the temporal lobe is the differentiation that what is the real and what is unreal. Let me tell you an example. This room and the people sitting here, I know they are real people, I hope. Now, I hope. Now, sometimes under some certain psychological disturbances, they perceive the environment in an unusual way, in an unreal way. For example, in some disease state, I may perceive all of you are made of cotton. Or I may feel all of you are metallic objects with mechanical movements. Do you think it's real or unreal? It is unreal. Is that right? So actually, temporal lobe is also concerned with the real and unreal differentiation. Let me make it more clear. I know your faces are confused. If there's temporal lobe tumors, it's a classical presentation of temporal lobe tumors or temporal lobe epilepsy. You know, if there are tumors, they irritate the temporal lobe. Or unfortunately, if someone has epilepsy focus in the temporal lobe, they come with very unusual things. You know what type of problems they come? They may come with olfactory hallucinations because olfactory cortex is there. So person with temporal lobe epilepsy may smell the things which are not there. He may feel all the time that he's smelling the roses, but actually there are no roses there. So there is no external stimulus, but patient is perceiving it. So it may be due to temporal lobe lesions, maybe tumors, maybe hemorrhage, maybe hypoxia, maybe ischemia, maybe some, you can say, epileptic focus, abnormal electrical activity focus. So patient with temporal lobe lesions, why I'm especially stressing it, because usually they're misdiagnosed. They may have they may have olfactory hallucination, they may have gustatory hallucination because taste area is also there. Gustatory means related with the taste. For example, you are sitting here very happily and you feel that some very good, your taste without anything putting in your mouth, you start tasting something very, very good food and you are starting enjoying the taste, but actually there is nothing there. So probably that area in the temporal cortex which was supposed to receive that taste, that is being irritated. So in temporal lobe epilepsy or temporal lobe lesions or drugs which specifically irritate temporal lobe or diseases in which temporal lobe undergoes dysfunction, right? You may find olfactory hallucination, you may find gustatory hallucination. These cortical areas are on the medial side of inframedial side of the temporal lobe, and on lateral side of the temporal lobe there is auditory area. And if there are lesions on the lateral side of temporal lobe, patient may have auditory hallucinations. In the same way, patient with temporal lobe may have some other problems. I told you that the temporal lobe is concerned with fantasy and reality. It is concerned to differentiate between real and unreal. Have you heard the terms called jamais vu and déjà vu? Déjà vu. I don't know what is the right pronunciation. And déjà vu, okay. Déjà vu and jamais vu. Now, déjà vu, what is a déjà vu? Who will define it for me?
When you go to a place and you feel like you've been there before.
Okay, you go to a place and you feel you have been already there. For example, you go to your medical school and you feel you have already been there yesterday. Is it déjà vu? No. Look. I will, in one word, I will give you the concept. It is undue over familiarity. Undue over familiarity. You are over familiar with the things unduly, right? For example, you are very familiar with your boyfriend, right? Now that is a normal familiarity. He has been with you for a long time, for 3 years, 5 years, so you are familiar. But if you meet a new boy today, you know that he's totally stranger for you today, he's meeting you first time, but you feel somehow you have met the person previously, right? That is déjà vu. So it is undue familiarity. Or as she said, you may go to a new place. No,
I missed that word.
yeah, you know, you have to. I'm preparing you for MCQs. Every word means something. You lose or gain, right? If you go to a new place and you feel that as if you have been there many times, and actually, in fact, it is totally new for you, then it is deja vu. So what is boys develop a, I say, what is that? Voluntary deja vu when they see any beautiful girl, right? They try to be over familiar. Oh, we know you, we saw you, we heard you, I mean like that. But that is not a deja vu, that is something else, but they're trying to, right? So what I'm saying, that deja vu is undue over familiarity with the thing. For example, someone who has never took a lecture from me, he comes in the class, he sits, and somehow he feels that he has been attending my lectures previously, and he has never attended any lecture. That will be an example of deja vu. Is that right? Actually, this is also a function of temporal lobe to differentiate what is new and what is familiar. You know, every day, you know, what are the things which are familiar with you and which are unfamiliar. Right now, if a person enters into your room, if he's your friend, you should recognize him as familiar person. And if you have never seen him, he should look as unfamiliar. This is also done, this function, by the neuronal connection in your temporal lobe. So when you develop problems in the temporal lobe, patient develop too much deja vu. Normal person may have a little bit deja vu sometimes, but if your patient is having too much deja vu, you have to look for the temporal lobe function. Then jamais vu. What is jamais vu?
Never seen it.
Jamais vu is never seen before. You have never seen many things, and if you see them today, it is jamais. You saw me today first time.
What?
You saw me today in the lecture first time.
Yeah.
So is it jamais vu? I hope not. No. Before you really come with totally unusual set of thought patterns, let me tell you, it is problem with differentiation of reality and unreality in the temporal lobe. Those central connections which really differentiate what is imagination, what is reality, and what is unreality, those are dysfunctional, right? And for you, the world looks unreal. Of course, examples are the best to make the concept clear. For example, if during the lecture I feel my all students are only 5 to 6 inches size sitting here, do you think it's real? No. Or for example, you are going in the market and suddenly you feel that every human being is just 1 feet tall, only you have the normal size, normal height. That is unreality. Or you find that all the people around or all the buildings around are made of cotton, and the people who are moving around, they are mechanical objects. Do you think that is real? That is unreal. So what is that? Jamais vu. So that is also a function of temporal lobe. So in temporal lobe lesions, a very unusual combination of features may come, that patient may develop olfactory hallucinations or auditory hallucination with deja vu or jamais vu, right? And with that, another problem. That is not hallucination but a real problem. Who will tell? Behavioral problem. Your temporal lobe, with its especially amygdaloid nucleus, is concerned with sex and aggression and many other important things in life. And if drugs irritate that area, you know what will happen? Patient's behavior may become very aggressive. Even some psychiatric, I have seen one mother who complained about her son who was just 8 years old, and she was very much tearful. She said, there's something wrong with my son, that from last 6 months, what he is doing, he catches any object and starts sex. An 8-year-old boy, you're not expecting to do sex, and he is doing sex with the chair, he is doing sex with the pillow, he is doing, maybe that is something normal, but not for an 8-year-old boy. Or he find anything, he will stand with the wall and start doing the sex there, sexual movements. I'm not going to show you. Now, I'm really very careful in lecture. What I'm saying, that mother was very much ashamed, especially because I saw him in Pakistan cultures, she was very ashamed, and everyone was telling the woman, people are not very educated, that mother has done some sin, and due to that reason God is very angry with the boy, and boy is not trained, that is why he's developing these habits, he is not going to spare anything in the world, or some nasty thing. But actually what was there? We just did the CT scan and found a tumor in his temporal lobe, which was irritating the amygdala region. That was it. Why I'm putting so much time on this? I know you're going to be doctor. Somewhere you may come across the patients with these unusual features which doctors ignore because they don't understand. And patients say that sometimes, I don't know, I'm just sitting in my room and sometimes there are very pleasant smells, but actually there's nothing. I keep on asking everyone, do you have a good scent? And there's nothing. You should think, is temporal lobe okay or not? Is that right? In the same way, when we say that some drugs produce very severe behavioral problems in their toxicity of the drugs, you must think that limbic system is being affected by the drug. Temporal lobe is a part of the limbic system which is concerned with the behavior. Is that right? Or when we talk about the drugs which control your behavior, they must be working on the limbic system, which is the behavioral central connections. Is that right? Whenever I say there's a drug which is antipsychotic drug, antipsychotic means that the drug is reducing the degree of psychosis. So it means that drug must be working on the limbic system. By the way, what is psychosis? Anyone? What is psychosis? Don't tell me it's a medical term you have heard somewhere. I want to know more than that. Oh my God. Oh, just a minute. I will put these terms we have to talk about. Psychosis, and of course we have to differentiate it with neurosis. We'll come to that thing. Right? Then how you study antipsychotic drugs if you don't know what psychosis? You are going to tell me about psychosis? Craziness. But someone who is extremely anxious, that also looks crazy to you. Someone who is obsessive, that also looks crazy to you. Someone who is, you can say, psychotic, that also looks crazy to you. So we don't define our patient with these terms. Then my patient develop craziness and I give anti-crazy drug. You get it? We are going to be doctor, right? So what is psychosis? Okay. Patient loses contact with reality. That is so simple. Loss of contact with reality. That's so simple. Someone has thought processes and mental processes which have lost the touch with the real world. Yes, schizophrenia. Do you think they are in contact with reality? Schizophrenic patients are not in contact with reality. They are psychotics. If I say a drug has produced psychosis, it means drug has produced some severe complications of thought processes and patient has lost the contact with the real world. Is that right? With many drugs produce psychosis as a toxic effect. You must know what is happening to your patient. We'll come to that anyway in detail. Let's finish it first. So you know visual hallucinations, auditory hallucinations, tactile, olfactory, gustatory, right? There are many other hallucinations. We'll not go into detail right now. You know deja vu, over familiarity, undue over familiarity, and jamais vu is feeling of unreality with the environment. Is that right? And these two, if they are excessive, they may be part of temporal lobe Leon system syndrome.